Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientists monthly webinar series. I'm Dr. Jeff Borenstein, President and CEO of the Foundation, and your host for today's webinar. Today, Dr. Francisco Xavier Castellanos will present, quote, Living Well with ADHD, Scientific Guideposts to Improved Outcomes, unquote. The Brain and Behavior Research Foundation is committed to alleviating the suffering caused by mental illness by awarding grants that will lead to advances and breakthroughs in scientific research. The Foundation is the largest private funder of mental health research grants. Since 1987, the Foundation has awarded more than $360 million to fund more than 5,000 grants to more than 4,000 scientists around the world. 100% of all donor contributions for research are invested in our grants to scientists who are working to find breakthroughs in disorders such as ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, OCD, post-traumatic stress disorder, addiction, and schizophrenia. I'm delighted to introduce Dr. Castellanos. He is the Brooke and Daniel Nedick Professor of Child and Adolescent Psychiatry and the Director of the Green Cowan Institute for Pediatric Neuroscience at the New York University Child Study Center. Dr. Castellanos is the recipient of the Foundation's 2015 Ruane Prize for Outstanding Achievement in Child and Adolescent Psychiatric Research and a Distinguished Investigator Grant in 2005. Today's webinar will begin with his presentation. This will be followed by a question and answer period. To submit your questions, please use the Questions tab on the control panel on your screen. Please feel free to submit your questions throughout the presentation. I will present as many of your questions as I'm able to in the time allotted after the presentation. And now I'm pleased to introduce Dr. Castellanos. Dr. Castellanos, the floor is yours.
Thank you very much, Jeff. Let me make sure that I've got this clicked. And
yes.
Has my slide come up?
Yes, thank you. Yes.
Good. So I want to thank the Brain and Behavior Research Foundation both for the incredibly important work that it's done over the years to support research from labs throughout the world, and everyone who's attending today and those who will listen to this on the web at future points. Let me just make a point that in my department, in my School of Medicine, we've made the decision not to get involved with commercial entities because of the complexities of maintaining objectivity, especially when we're dealing with issues that are as fraught with potential controversy as some of the ones that I'm going to touch on today. I also want to acknowledge that I've worked on the DSM-5, which is the diagnostic system that's used for conditions such as ADHD. The outline for today's talk is to touch on very briefly the diagnosis of ADHD, and some of the considerations that are important when we're evaluating individuals to determine whether or not they have it, and to really hammer home that although ADHD can have very good outcomes, it really also can be quite concerning and needs to be something that we continue to try to improve how we evaluate and treat this condition. I'm going to briefly mention some of the research on the brain in ADHD. And I do want to note that last fall, I gave a talk that was really focused on these issues, which is also available on the website of the Foundation. And for those who are really interested in more technical aspects, I would recommend looking at that. The gist that I'm going to focus on is that the information we have about brain development in ADHD suggests that there is a brain basis for the kind of delayed maturation that we also observe socially and functionally. And the bulk of the talk will be focused on some of the challenges of ADHD and the theme that we really have to separate out the very important targets of avoiding what I like to term irreversible errors from those that are basically learning opportunities, and we can, not have to worry about lifelong consequences. And the core principles of psychoeducation, which embody these. So DSM, the Diagnostic and Statistical Manual, the 5th edition, which was published 3 years ago, made very few changes relative to the previous edition, the DSM-4, which goes back to 1994. And I won't go through each of these points in detail. They will be available on the web for anyone who's interested in looking at this in the future. But I want to say that these 6 hyperactive symptoms and these 3 impulsive symptoms of blurting out, being impatient and intrusive, as well as the 9 symptoms of inattention, don't look all that different from what everyone does at any given time. What differentiates ADHD is the frequency and severity of the consequences of having these more than one would expect for any given individual's developmental stage. And when we think about ADHD, we also have to consider other conditions that commonly co-occur. Maybe 25 to 40% of children with ADHD also have specific learning disorders. Dyslexia, dyscalculia, for example. Another 25 or so percent will have oppositional defiant disorder, difficulty with anger, resentment. Anxiety disorders are quite common across the age ranges and certainly can occur with ADHD. So can mood disorders such as depression. Having ADHD doesn't protect from these. At the same time, some of the symptoms of ADHD may be the result of anxiety or depression, etc. And so, again, that's part of the complexity, that's part of the training that clinicians undergo in order to feel more confident about what exactly is going on with a given individual. There are also conditions that can be confused for ADHD. Again, having one of these does not mean that ADHD might not also be present, but it's important to differentiate difficulties an individual may be having, perhaps because of a traumatic experience and all of the aftermath of that. Reactive attachment disorder is particularly found in individuals who had, let's say, were orphaned and in an institution and did not have the ability to bond and engage with a primary caretaker from the very earliest age. And that can produce difficulties in relating to others that can be enduring and long-lasting. Autism spectrum disorder is also frequently found in comorbidity. It's termed, it co-occurs with ADHD. But there are times when we think perhaps it's predominantly autism, not ADHD, or vice versa. I've already mentioned mood disorders. There's a new diagnosis of disruptive mood regulation disorder that we're still kind of working out. Bipolar disorder, especially in adolescents and adults, can frequently both co-occur with ADHD and can be confused one for the other. Finally, substance use disorders are frequently consequences of conditions like ADHD, but they can also make it worse. And you don't have to have ADHD in order to develop one of these, but if you become addicted or have enough problems with substances, then certainly you're going to not be functioning very well and you could meet criteria for ADHD, but we wouldn't call that classic ADHD. And really finally, I said finally before, sleep disorders also need to be considered because not sleeping is not good for the brain. It's not good for lots of parts of the body, but the brain is one of those. And in fact, individuals will have more of a tendency to show ADHD kinds of symptoms with various kinds of sleep disorders. It's also common for people with ADHD to not be disciplined about when they go to sleep, et cetera. And so that becomes a kind of a chicken and egg problem. In summary, though it's not a trivial process, the diagnosis of ADHD is actually being done fairly well in most settings. We can always improve, but when we compared all the diagnoses, all the major diagnoses in psychiatry, ADHD was one of the most reliable. That means that two clinicians, independently of each other, tended to agree more frequently with ADHD than most of the other conditions we have, because by definition, psychiatric conditions are complicated, and perspective and subjectivity always enter into this. And until we understand the real causes, this is always the case, and we are far from truly understanding how ADHD occurs, what are the mechanisms. That's part of why there's a great deal of interest in doing so, and that's where the research is focused, is on trying to understand what the brain mechanisms are. We don't yet have it for the most part, and so we still have to deal with these descriptions. I have to say they work surprisingly well, although we want to improve them even more. What has changed undeniably over the past few decades is the awareness of ADHD. When I was a child, no one thought about it, knew about it. These days, you can't turn on a popular program on television or anywhere you look without hearing about it or being exposed to it. And so that has raised questions as to whether or not we're seeing a lot more of it now than there used to be, and what's up with that. There was a very elegantly done study a few years ago which examined this question, and the bottom line is at the bottom of the slide, which is that worldwide, across a number of well-done studies, there's been no real change in how frequently individuals are found to have ADHD. Here's that slide from Polensik et al., which was published 4 years ago, and it shows from studies literally throughout the world over the past, from 1985 until around 2015, that there's been no net change. The straight line is the mean, and these dashed lines are the confidence intervals. That we have 95% confidence that the real value is within these boundaries. And each of these dots is a study. The smaller the dot, the better done the study, the larger the sample. The bigger dots have more uncertainty, and yet you can see that essentially no change. So that's important to know. But let's go from that big sort of worldwide perspective to a much more focused question, which is ADHD really a serious condition, or is this something that, as we once thought, people are going to grow out of? It's just a temporary childhood condition. Rachel Klein and her colleagues, starting in 1970, started a landmark study. They recruited children between the ages of 6 and 12 and followed them for the next 33 years. I was privileged to be part of that last wave of this study over the past decade or so. And in looking for these individuals once more, this was the fourth time they were evaluated since childhood, we found a number of outcomes that were really quite concerning. As you can see, there were 3 times as many individuals who were probans, who had childhood ADHD, who had been incarcerated at some point during this follow-up interval, compared to a not insubstantial number of the comparisons, 12%. These were essentially middle-class to lower-middle-class individuals, most of them Caucasians, most of them from Queens or Long Island, and there was a lot of experimentation with drug use, et cetera, in the 70s and 80s, really throughout the world, but New York was not, that wasn't absent in New York. Shockingly, this was the first observation of an increased rate of death in individuals with ADHD compared to a prospectively collected group of comparisons. Almost 3 times as many individuals died, and we'll come back to this in a bit. We also found a very large increase in conduct disorder. Those are violations of social and legal norms, more serious problems with antisocial personality disorder, also vastly more likely in individuals with ADHD. No differences in alcohol problems, although they were quite substantial in both groups, but a higher tendency to have other kinds of illicit substance use disorders, and twice the rate of nicotine dependence, which again, it's many samples, many studies have found, is one of the chronic difficulties of being an adult or an adolescent with ADHD. In this sample, no differences between the groups in mood disorders, that's depression, bipolar disorder, etc., or in anxiety disorders. Again, about what you'd expect in the population for anxiety disorders, it's quite substantial for mood disorders in these samples. Now, turning to the most severe of outcomes, there were no differences in medically related deaths. There were, for example, 2 deaths by cancer in both groups in their 30s and early 40s. There was 1 individual who died of diabetic coma, another individual in the comparison group who died of complications of AIDS. There was 1 heart attack. But all told, these were very comparable proportions, and so this was not where the differences in deaths lay. Instead, there was a huge overrepresentation of premature deaths from non-medical conditions. And these included 3 suicides at ages 21 and 2 at age 30, an overdose from either alcohol or drugs in both groups, one at age 39, the other at age 26, but 2 victims of homicide in the group of ADHD probands. 2 had deaths on the job. One was a pilot, the other was a firefighter. One was hit by a car, another one fell from a roof. He had locked himself out. He decided to climb to the 2nd story to break into his house and literally died. One was a victim in the 9/11 terrorist attack on the Twin Towers, and one we know died, but we didn't have a cause. A vast overrepresentation of preventable deaths in the group of individuals with ADHD compared to the comparisons. This is in a relatively small study, about 200 per group, but followed over decades. More recently, this has been confirmed in a gigantic study. These are the kinds of studies that can be done in Scandinavia. This group examined almost 2 million Danes. This included 32,000 people who had been very carefully diagnosed with ADHD, and they were followed for a total of 25 million person years. So obviously they didn't do this for either 25 million people, but it's those 2 million people roughly for about 12 years apiece. During that period of time, about 5,600 people died, and they were able to document that the death rate from ADHD was 2 to 3 times higher than those without ADHD. And this was mostly ascribable to, again, accidents or unnatural causes. Interestingly, when they statistically removed people with other kinds of conditions that also increased the risk, oppositional defiant disorder, conduct disorder, and drugs, there was still an increase of mortality in individuals with ADHD. Frighteningly, when they looked at the people who had all of those conditions, they had an 8-fold increase in risk of mortality. So again, I think by all of our usual standards, this qualifies as a serious mental disorder. Again, coming back to the theme of accidents, this was confirmed in a large study in Sweden. In this case, Chang et al. And Paul Lichtenstein and colleagues at the Karolinska compared 17,000 patients with ADHD over a period of 3 years, from 2006 to 2009. They found about a 50% increase in the risk of serious accidents in both men and women with ADHD. In men, medication use, which they were able to track because in Sweden the system is a single agency that pays for all the medication, and all of this is centralized. So they knew when people were getting their prescriptions, and they were able to identify that if someone was being treated during that 6-month period, they had a 58% lower risk for the men of having an accident. The improvement in women was not significant. It's not completely clear why that's the case. Perhaps because there were fewer women, they would have needed a larger study to detect that, but that's a bit of a speculation. At any rate, another study, again in Sweden, in a similar design, 26,000 men and 12,000 women, were followed to see, is there a concern, is there a worry that giving people stimulant medications, which we know can be abused, can produce addiction, will that actually make things worse? And the simple, short answer was no. In fact, there was pretty good evidence that it was actually protective in adults. There was about a third less substance abuse in those who were prescribed medications for ADHD 3 years before this, the end of this follow-up period. And the longer people were taking medication, the lower their risk. The same kind of findings were suggested for children. So these large-scale studies have given us a substantial amount of reassurance, as well as identifying some of the major risks that we've known about, but really sort of quantifying them and validating the importance of this issue. So to turn to one of the core questions of that many individuals say, you know, my child has been diagnosed with ADHD, but I had these same characteristics when I was a child, and I was never given the label, and I'm glad I wasn't. Isn't there a cost for carrying this label, for being potentially stigmatized? And it's a complicated question, and we can't simply say, oh, no, there's no problem. On the other hand, we do have to think hard about when is this important to think about a diagnosis. And the United Kingdom's National Institute for Clinical Excellence, this is a great acronym, NICE. So these are the NICE guidelines, but it doesn't have to do with how nice people are, but rather that it's a focus on clinical excellence. They've studied this extensively based on thousands of articles that have been published around the world. And they've concluded simply that it's appropriate to make the diagnosis, first of all, when you meet the criteria that I've very rapidly touched on, DSM-5 or the non-US version, the International Classifications of Diseases, 10th or eventually the 11th version. But in bold, I've emphasized that there has to be at least moderate psychological, social, or educational or occupational impairment in multiple settings. And so I want to emphasize this notion of impairment, because that's really the basis on which we say we need to proceed, we need to go through this process, do an evaluation, come up with a treatment plan. Impairment is the key question. If a child is struggling a bit but managing, then we can watch. We can maybe not, be too aggressive. But when this becomes a chronic issue, most kids start to think, and sometimes they'll say, I'm a failure. That's the polite way of saying it. I don't want to, be too colloquial. But they'll say, I hate school, I hate my teacher, or my teacher doesn't like me. These are huge red flags that speak to the sense of, I'm not making it, that this child is experiencing. And we can't say in any single case simply, well, this is what causes oppositional defiant disorder, conduct disorder, etc. But we know statistically that these are more likely in such cases. So what do we do? Well, we think often of, medicines. And medicines can be very useful. But I want to focus in this talk especially on a fancy word, psychoeducation. It doesn't mean education for psychos. It means psychological education. This is really the core of all treatment, even though we sometimes just assume it. Part of what needs to be taught to the family and eventually to the patient is what ADHD is and is not. all too frequently people are convinced that he or she is doing this on purpose. They're just doing this to annoy me. Look how well he or she can behave when they want to. We now know absolutely it's not voluntary, it's not intentional. I'm not saying that kids don't sometimes want to annoy the adults around them, but that's not the simple explanation for this. We know that the causes are mostly genetic and neurodevelopmental, things that happen during brain development. It's not a simple issue of bad parenting. On the other hand, becoming a calmer and more effective parent does help, but the obverse is not the case. You don't create ADHD by, just not being quite good enough. So, what are the goals of treatment? Well, in a sense, the good news with ADHD is that it's possible to have excellent outcomes. Some of the most celebrated, founders of companies and great heroes, etc., are now proud of talking about their ADHDness in childhood because they've really overcome so much. And so one can be extremely successful, can be productive, can have a happy family life, and having had started out with ADHD. On the other hand, I've already kind of hammered that there's an elevated risk of death, of serious accidents, overdoses, etc. Addiction is a serious problem. And even when the outcomes are good, it's not a simple, downhill path. There can be lots of twists and turns. And though I don't see patients in the clinic these days, I did for many years. And part of what I realized that it was important to help parents and families differentiate the issues that we really have to worry about from things that we shouldn't get too upset about. Haircuts and, even piercings and things like that can be quite annoying, but they're not at the same level as the irreversible mistakes. And here, at least for me, is my list of the short list of irreversible errors. These are the targets. These are the things that we have to try and prevent at all costs when dealing with individuals with ADHD, especially children and adolescents. Because once these occur, life is never the same. First of all, if someone has died, that's obvious. But if you become addicted, your life is never the same. You always have a greater risk of relapse. You can no longer be, flexible or casual about it. If you have a viral infection, it may not be that you die, but you will always have to deal with those consequences. And in the U.S. and in many countries, even being arrested of a serious crime, such as a felony, is something that you have to explain for the rest of your life. Every job application, every college application, and people look at you differently, and so you carry that burden. The last one of these, one could argue about, but I do think that having children is such a life-changing event that in many cases doing so before people with ADHD have made it through their educational process, etc., really changes their trajectory and that of their children, because now they're no longer able to stay in school and to get a good job and to have a career, etc. And so these, I would suggest, are the targets, the things to prevent. Everything else is a learning opportunity. Bad grades, flunking out, it's all regrettable, but it's not life-changing. There are thousands of cases of individuals bouncing back from those and being able to succeed and triumph. So how do we make this, work? Well, adolescence is when most of the risks associated with ADHD either occur or begin. And by the time someone is 14, 15, or 16, sometimes parents who have been hoping that this was going to go away and not be an issue finally say, okay, it's gone too far, we need to get help. And then they try and get their adolescent into a psychologist or psychiatrist's office. And it's not easy. In fact, it's super hard to start at that point. By this point, there's been so much anger, so much recrimination, so much resentment. By this point, the adolescent is frequently embedded in a peer group that essentially has replaced the parents as the source of social support and sense of belonging. And so it can be very difficult to kind of have a way of motivating and really kind of effectuating change. Ideally, we establish what's called a therapeutic alliance, a relationship long before. And then the challenge is maintaining it through the transitions of adolescence and young adulthood. The principles of how to support someone through this process go back almost 100 years, and they're very well known, but they're not natural. As human beings, we naturally pay attention to problems and we ignore the situation when it's going well, which is the opposite of what has to happen in order to support someone behaviorally. And so this is why parent training is such an important part of helping individuals with ADHD, children with ADHD, improve. Now, more than a few words about medications. I have never known a parent who didn't either say or think, will giving my child these medicines damage his or her brain? It's terrifying to think about not just 7 to 10 days of the medicine, but months and years and maybe decades. And people always want to know and frequently ask, do you know for sure that these medicines are safe? And the problem is the for sure, the completely safe. The simple answer is we never know for sure. On the other hand, we've been looking as best we can for years and in some cases decades. And we have no credible evidence in either humans or non-human primates, monkeys that are as close to humans as we can ethically get, that the usual doses of stimulant medicines are going to damage the brain. There's no question that you can damage the brain with certain kinds of stimulants if you inject them, if you take them in super high doses, that does occur. But taking pills as prescribed is not been shown to be harmful in a serious way, with exceptions of extremely rare kinds of allergic reactions. At the same time, we cannot and we never will be able to claim absolute safety. There's no such thing. Now, what's the basis for this? It's indirect, in part because there's no way to take a large group of children who've never been treated for ADHD and get their parents to agree that we're going to randomly assign half of them to no treatment and the other half to medication, not tell them for years, and then see what happens. That will never happen. And that's the only way to determine absolutely whether there are risks or not risks. It would have to be a very large study. That's never going to happen. So everything we do is indirect. And I was part of a study that was published more than almost 15 years ago now, in which we looked at brain size of various regions and looked at this in boys and girls with ADHD, found a number of differences, but we looked also very hard for children who had never taken even a single pill. We wanted 50, we got 49, and interestingly, the 49 kids who had never taken a medicine had the biggest differences. In other words, their decreases in brain size relative to the comparison groups were greater than those who had taken medication. We can't say for sure that taking medicine would have made their brains larger, but we can say that the smaller brains in the kids with ADHD were not caused by taking medicine. In that same study, which was then continued by Philip Shaw when I left NIH, looking at now the thickness of the gray matter, so-called cortical thickness, Philip made an amazing observation, which was published now 8 years ago, which is that there are differences in the rate at which the cortex matures. And these are so-called brain maps with the colors show the areas in which there were differences, more than 2 years delay. And in fact, in the very frontal parts of the brain, there was up to a 5-year delay in the rate of brain maturation between kids with ADHD and those healthy controls. That's a gigantic difference in a physical parameter. And it suggests that, again, this may well be the biological, the physical basis for the delays in social and emotional maturation that we frequently observe in most individuals with ADHD, especially these frontal, prefrontal areas of the brain. Those are the ones most involved in self-regulation, in controlling our impulses, in thinking before we act, etc. In follow-ups to that study, Philip compared children who were taking medications, 24 treated, those are in the blue, versus those who were not taking medicine, and in the green, controls. And what was interesting is that those on medication look more like the controls than the kids who had stopped taking medication for whatever reasons. Again, it doesn't prove it, but it's consistent with the notion that medication may be actually helping to normalize some of these physical parameters. And in a different kind of study, what's called functional MRI, Katja Rubia and her colleagues in England showed, again, that differences in brain functioning between kids with ADHD when they were taking a placebo and the control groups, especially in these frontal parts of the brain, resolved or disappeared when they were taking medication, in this case, methylphenidate, which is frequently known by one of the brand names, Ritalin. It can also be called Concerta or Focalin or Metadate, etc. There are a number of different brand names. At any rate, these are suggestions. They're consistent with the idea that there's a kind of normalization going on in at least some of the parameters that we're able to observe and measure. Now, we can't ethically randomly assign large numbers of children to long-term studies of medication or placebo, and we can't really do that in very large studies of monkeys. But in a study which is very large by monkey standards of 8 young monkeys per group, Linda Perino and her colleagues looked at what would be the effects on a large number of parameters, including weight and height and body mass index and brain measures and brain chemistry between those who were treated with placebo or the usual doses of medicine that are used for children for an entire year while the monkeys are growing up. And you can see from these plots there were absolutely no differences between the groups. And in this busy slide, which again, if you don't read it all, it's going to be on the web, they concluded that their data supported the hypothesis that methylphenidate, the most commonly used stimulant in most parts of the world, administered in the doses and in the ways in which it's given to children, does not have obvious long-term effects. In addition, there was no evidence of an increased vulnerability for the reinforcing effects of cocaine, in other words, for the likelihood of producing tendencies to abuse drugs such as cocaine. And finally, they said the absence of any significant long-term developmental, neurobiological, or behavioral consequences provides further support that the use of these medicines to treat ADHD will not negatively impact children either during or after treatment. So can we be certain that these medicines are completely safe? No, because every medicine has risks. But at the usual doses that are given to children or older individuals, these are amongst the safest medicines we know. In all cases, we still recommend starting as low as you can, using the lowest effective dose, and always monitoring for adverse or side effects. Now, that, in a sense, was the easy part, because in many cases, medicines can be tailored and adjusted and made to be really relatively optimal, and things seem to be working well. But we used to think ADHD was only a condition for elementary school-age children. We now know that problems related to ADHD can really last a lifetime. And it's especially problematic in academic environments, but it can occur in a number of different settings. And yet, it's very difficult to maintain this relationship with the child and the family throughout the transitions of adolescence. Kids who will do what their parents and their doctors say become adolescents who insist that they make their own decisions and you're not going to tell me what to do. And all too frequently, this is when things founder, the adolescent says, I'm not going to see that person anymore, you can't make me, and it's true. And so I really think we need to pay attention to this and lay the groundwork for this transition from the very beginning. And in part, I recommend that all clinicians become future, predictors, seer-sayers, and let the families know that at some point, usually between ages 10 and 12, all children with ADHD, even if they've had a terrific response to medication, are going to say, do I really need to take this? I don't know that I still have ADHD. Usually the first time they say something like this, it's done very tentatively. But when that's ignored, the second, third, or fourth time, the child all of a sudden says, you know what? I've decided I'm not going to take this anymore. And furthermore, you can't make me. And I know you just want to use this to control me, and you're going to make me a drug addict. Look what people say about these pills, et cetera, et cetera. And the fact is, we can't make them. No parent can force a pill into a 13, 14, or 15-year-old's mouth and wouldn't want to, even if they could. So what I really recommend is that as soon as any such doubt is raised by a child or young adolescent, the parents have to notify the physician immediately, even if it's been a year since the last time they saw each other, and say, it happened. At that point, the clinician needs to discuss this with the child privately. The parents are aware of it. They might be outside in the waiting area, but let the child in and talk about this themselves. At that session, it's important to really acknowledge it may not be necessary for you to be taking medicine, maybe anymore, especially maybe not this year. You're in a great school, you've got good friends, you've worked things out, sounds like things are going great. Brain maturation is on your side, that continues to improve, and so maybe this is unnecessary. Let's find out. How about you stop for, at least 2 weeks or up to 2 weeks, because if you just stop for a day or two, because that's frequently what happens, is kids will forget or their parents will forget, and the child will say, nothing bad happened yesterday. I don't think I need this anymore. Well, once or twice doesn't really tell you anything. But it's important to do this for a longer period of time. And ideally, at least a month has elapsed after the beginning of school, so that there's a sense of a baseline. Really, ideally, it's near the end of the year because everyone sort of knows what to expect, and so you can notice if there's a change. But here's a critical point. The timing is up to the child, because if you push around too much and say, no, I know better, they just kind of say, people aren't going to listen to me. I'm just going to opt out of this whole thing. So they're in control of when, and now their task is to see, do you need this or not? It may not happen immediately, but let me tell you a few of the things to look out for. Over the next couple of weeks, do you notice that, the day used to go kind of quickly, but now all of a sudden it seems like 3 o'clock is never going to show up? all of a sudden, teachers that seem to be okay, you think, oh, they're so boring. Are you forgetting things all of a sudden that haven't been a real problem? Do you wind up doing things impulsively? Obviously, we don't use these words, but you get the idea. If any of these are happening and you kind of notice this, I tell them you don't have to ask anybody's permission. You can just start taking the medicine. You don't have to wait till you come back in here. It's up to you. And, totally your call. I've not done this as a study, so I cannot give people specific numbers or statistical information, but I do recall that it was amazing how often I would ask, did you ever do that, trial we talked about? Oh, yeah, I did, but then I started taking it again because it seemed to be helping, or something like that occurs. And the crucial thing that's happened is that instead of being told you have to take this, the child has now decided, actually this seems to be okay for me. Now, it's possible that one of the reasons why they're reluctant to take it is because now they're developing side effects that they didn't used to have. They don't have as much of an appetite, and that didn't used to be a problem. That occurs in some fraction of kids, in part because puberty and adolescence produce metabolic changes which can actually require a lower dose, even though they're larger and heavier, in part because the liver metabolizes these medicines. And so the fact that the liver is busy with estrogen and testosterone can actually produce a slowing. And so one of the first things to do is when side effects emerge that weren't there before, lower the dose, because we may be overdosing now. In some, part of what then becomes the task is for the child, the adolescent, to figure out for themselves what works. I tell them, you have to figure out your own owner's manual. Everyone needs one, but you don't get one in, online anymore. You've got to create your own. And the clinician's job is to tell you what's safe and what's not safe. But within those limits, you've got to figure out what works for you. I cannot control you. Your parents can't either. It's up to you now, especially when you go away to school. But that's the reality, and I think we have to just acknowledge that and work with the young individuals so that when they truly are on their own, they can continue to make good decisions. So let me conclude by hoping that I've convinced you that treating ADHD and thinking about this as a potentially lifelong condition can be rewarding for all concerned. It's certainly been extremely gratifying when I've had those opportunities. But it requires a lot of patience, perspective on what really matters, and an awareness that we need to be optimistic, that as long as irreversible errors have not occurred, and if they have, then we figure out how to minimize those consequences. But as long as those haven't happened, life is good. And that maintaining the therapeutic alliance is challenging and crucial, but can be done, and needs to become a crucial target. And finally, that one of the great things about working with young people with ADHD is that brain maturation. Nature is on our side. The brain continues to improve through at least the mid-20s, actually the mid-30s and 40s. But there's a reason why you're not allowed to rent a car before age 25. There's a reason why you can't be president of the United States before age 35. You just don't have the judgment. And so as those faculties continue to improve, the problems related to ADHD diminish more and more as long as the irreversible errors have not occurred. So with that, I will stop, and we'll see if there are questions that have been passed on.
Well, first of all, let me just say thank you very much for an outstanding presentation. And I think that your words, your approach, your guidance shows not only the strength of the research that you've been involved with, but also what an extraordinary clinician you are, and how caring and how you're able to really engage the children, the adolescents, and the parents. So thank you for your presentation. One of the areas of questions relates to non-medication approaches that could be used either with medicine or without medicine. I want to see if you could take a couple of minutes to speak a little bit about approaches above and beyond the education. What other non-medication approaches could be helpful to people?
Absolutely, and I very much glossed over them rapidly, but one of the keys is what goes by, the inelegant term of parent education or parent training and behavioral management, which is really helping parents and teachers to identify the behaviors that we want to encourage and address the ones that are getting in the way, ignoring whenever possible, and or using small penalties to try and decrease those frequencies. These are techniques that are extremely powerful. They just require a lot of attention, a lot of being thoughtful and aware on the part of the adults. That takes a lot of practice. It takes a lot of encouragement. But we know that those are profoundly important and effective. And in fact, it's ideal when that can be initiated before the medication. Bill Pelham and his colleagues at Florida International University have shown that although you can start first medicine and then do behavioral, or first behavioral and then medicine, and many people have argued both ways, you actually get better results if you start with the behavioral first and then add the medicine. In part, people take the behavioral more seriously, and you get more benefit from the medicine when it gets added to an effective behavioral program. More recently, there's a little bit less compelling data because it's not been done for as many years, but there's been a lot of interest in approaches that include everything from mindfulness meditation to, again, kinds of cognitive therapies for adults, paying attention to the consequences of behavior. And a colleague, Mary Salanto, and others have done very well done studies documenting that these are also effective treatments for individuals with ADHD. In general, we can kind of summarize some of these. In part, it's about developing habits. A simple example is if you're always losing your keys, or can't remember where you put your phone, then always developing a rule where the second you walk in the door, your keys go into the bowl by the door, and getting that habit in place helps to prevent that difficulty of running around trying to find where the keys are. And so turning decisions into habits is one of the strategies that can frequently be helpful.
Good, very good advice. A question about the medicine. You made the important point of treating at the lowest dose necessary, adjusting the dose even downward, especially downward if need be. There's a couple of people asked the question about if a person is off from school the child's off from school during the summer or on weekends or holidays, not taking the medicine. And I'm curious what your experience is in terms of those vacations from the medicine.
Exactly. So again, each of these has to be personalized, because if there's no side effects, if the child is growing well, if their appetite is good, if they're sleeping without any difficulties, those are all sort of common potential problems. And if none of those are occurring and everyone prefers the evenness of medication every day, that's acceptable. On the other hand, for kids that have less of an appetite at lunch, or their growth is not what it could be, etc., then considering whether you can have a vacation from medicines during the summer or even on weekends is worth considering. It's safe to do either one, as far as we can tell, and so it's got to be tailored to the specific situation. Now, with adolescents, they really have to be part of this. There's some adolescents that say, I'm going to take this for school because it clearly helps, but I want to be, my giddy sort of playful self on the weekends, and I'm not getting in trouble with driving, and I'm not doing impulsive stuff, but I feel more able to be like that, and so that's the choice I'm going to make, and that's reasonable. On the other hand, accidents are a big problem, and we know that again, stimulants do produce better driving when it's been tested with things like driving simulators, etc. And so all of these things go into the kind of long-term relationship with a clinician. This is not a one-time deal. This is a relationship over years and decades that has to be adjusted and optimized for all the different conditions.
Often when a child has a diagnosis of ADHD, they're able to have additional time for testing. What's your experience with that, and how that has the effect that has on the child?
So again, that has to be, yes, that in many settings, that's one of the accommodations that's provided. In part, that has to do with the fact that on average, most people with ADHD are less efficient. They take longer, and so to kind of make things more comparable, having a bit of extra time helps to really show what they know. Frequently, or at least for some people, it doesn't help because their style is to be very impulsive, and they want to get out of there as quickly as possible. So again, it depends on the person, and there are psychologists who can assess this and look at the processing speed and look at how someone performs with or without timing restrictions, etc. And so that can be helpful to really determine when this is optimal or beneficial. The other side of that is that it's important to help folks with ADHD to kind of counteract their general impulsivity and to say, don't just immediately stop when you think you know the answer. Figure out a strategy for checking to make sure that you're not missing something, because you're going to have a tendency to miss some of the details and to jump to conclusions. So how do you, work out your own strategy to double check? And in part, again, that's where the extra time can come in, because when you have to do that, it's going to take you a little longer.
Very helpful advice. One last question I want to ask, which is the use of the ADHD medicines for people who may not have the diagnosis of ADHD but are trying to concentrate better or do better on exams. And I'd like to ask you to comment on that.
It's such a difficult question. We know that there are lots of cases and examples of these pills, and not just these pills, but benzodiazepines and even more worrisome, narcotics, etc., being passed around and taken from medicine cabinets, etc. It's not something I'm encouraging, but I do want to, have some perspective. I've seen people who are addicted or who had developed serious problems with stimulants. It's relatively few. Many decades ago, there were many more, and certainly cocaine and methamphetamine are scourges even now. But those are examples of how these drugs can be used in really quite self-destructive ways. Someone who is getting their friend's ADHD pill for dealing with the upcoming exam is not needs to find better ways to do that in the future, but I'm not going to be as worried about them as I am with someone who might be getting somebody's Percodan or Percocet and then getting more of those, in part because the potential for addiction with opiates, as we've learned recently, is really so extreme. Vulnerable people can really get in trouble with those, and before you know it, they're hooked and they potentially are dead. That cycle does not occur in the same way with stimulant medications.
Okay. Very, very good point on that. I want to again thank you for, first of all, the work that you've done in this important area through the years, the work you're continuing to do, and also for joining us today for an extraordinary presentation on this important topic. So thank you so much for all that you do. I also want to thank our audience for joining us today. All of the research we fund is made possible through private donations. And if you'd like to make a gift, please visit our website, bbrfoundation.org, or call 800-829-8289. This webinar has been recorded. If you've missed any portion of the presentation or would like to share it with a family member or friend, please visit the webinar page on our website. I also hope that you'll join us again next month when Dr. Herbert Meltzer, a Foundation Scientific Council member and recipient of the 1992 Lieber Prize for Outstanding Achievement in Schizophrenia Research, a 4-time Foundation grantee, and professor of psychiatry and behavioral sciences and of physiology and professor of psychiatry and pharmacology at Northwestern Feinberg School of Medicine, will present a webinar titled A Beautiful Mind, John Nash, Schizophrenia, Game Theory, and Recovery from Schizophrenia with and Without Medication. This will take place on Tuesday, October 18th at 2 p.m. Eastern Time. Once again, thank you and enjoy the rest of your day. Take care.